Hi, I'm Dr. Shah with 360 Urology. We're a practice located in Atlanta, Georgia. We're actually 15 minutes from the airport. We're about 15 minutes from the city. The city is actually called Stockbridge. You should come visit us. I'd love to tell you more and teach you more. I love teaching with my hands, and today I'm going to teach you about enlarged prostate. Enlarged prostate is one of the most common things that any male over the age of 40, usually 50s, 60s, will experience. It's the cause of frequency, urgency, waking up at night to go to the bathrooms, weak stream, hesitancy, intermittency, which means you have this start, stop, peeing pattern. That is your cause, or the primary cause of all of those problems in men. Now, a few things to know. This is my terrible drawing of your kidneys. So these are your kidneys. These are the ureters. These are the tubes that drain the urine. As they're made in the kidney, they get drained downwards, and they are stored in the bladder. And of course, right at the opening of the bladder, this is the channel you pee out of, right at the opening, you have your prostate. Now, what happens is as you get older and older and older, especially after the age of 40, this prostate right here starts growing more and more and more. And when it grows, it starts squeezing this inner channel that you pee out of, almost like a donut kind of enclosing it. And when it squeezes that inner channel, now the bladder really has to work to try to push urine past it. And when this bladder has to work, it's just a giant muscle. It has to squeeze harder and harder and harder to increase the pressure inside of the bladder so that you have enough pressure to push past the resistance of the prostate, right? Just physics 101. Now, what happens when you go to the gym and you start lifting weights and you're just cranking these heavy weights? Your arms get larger and larger and larger, or your chest muscles, whatever you're working out. And the bladder is no different. It's just a muscle. So when it's working harder and harder and harder, well, guess what? It starts getting thicker and thicker wall. And unlike the rest of the body, the thicker bladder wall is not sexy. In fact, what happens is the opposite of sexy. You end up finding that your bladder just cannot stretch. It's supposed to blow up and stretch like a balloon to accommodate more urine. And it just can't do that anymore. It's almost more like a tin cup, right? You fill out that tin cup, eventually it's going to explode. Well, or overflow. And so that's kind of what happens. You go from a balloon to a tin cup bladder. And this bladder can no longer hold as much as you would like. And so thus you already start going to the bathroom more frequently because your bladder just cannot hold as much urine. Other things that happens, the bladder knows it cannot hold as much urine, and it gets frustrated because it's losing that ability to squeeze. It's becoming actually weaker rather than stronger because it just cannot squeeze that urine out because it cannot inflate to squeeze the urine out. And so it starts getting urgency where it tells you, hey, listen, I'm going to tell you when I'm starting to reach a point of not being able to squeeze this out. And the way it tells you is just start squeezing without you telling it to, and you're running to the bathroom so that you don't leak. We call that overactive bladder urgency. And then you find yourself, because you can't hold as much urine, you find yourself waking up at night quite frequently to go to the bathroom. And each time you go, you may notice the volumes aren't quite as much because your bladder has to still work hard to push past it. You may notice it takes a minute to get started. You may notice that you have a weak stream because even as it pushes past that, it's not a very strong stream. You may notice that you leak, you can't even make it to the bathroom because you just can't hold it long enough because that urgency has reached that point. So those are all side effects and symptoms of enlarged prostate. Now, this is different from prostate cancer. Prostate cancer is typically a disease of the outside of the prostate. And that's why if this is the rectal wall, the bowel wall, the area you poop out of, we put a finger in there and we're pushing up against the bowel and we're feeling the prostate on the outside of the bowel, and what we're doing is trying to feel for any nodules. So the rectal exam is really more of a study for prostate cancer, less of a study for enlarged prostate. So in case you're wondering why proctologists put a finger up your butt, that's why, and it's not necessarily for enlarged prostate. Now, going back to enlarged prostate, what do you do about it? Well, now the world is moving more towards, as we have like more and more minimally invasive treatments, we're moving more towards bladder preservation. What we're trying to say is, hey, let's not reach a point of no return. And what is a point of no return? Well, what can happen if you do absolutely nothing? If you do absolutely nothing, maybe absolutely nothing will happen, or you'll just have symptoms that you're not worried about. But there are points of no return, as in your bladder may get to a point where it'll never reverse backwards. The worst case scenarios that we worry about is the pressure getting so high in the bladder because the bladder doesn't have the ability to stretch to reduce that pressure, and it starts going backwards up the kidneys and starts killing your kidneys off. We've seen end-stage renal disease because of this. Another scenario that we don't want is the bladder gets so overworked that it just stops working altogether and it loses function. And we call that neurogenic bladder, secondary to enlarged prostate. So those are scenarios that you don't want to deal with, but can happen, and unfortunately we see them. So that's why the world is kind of moving towards bladder preservation. What we're saying is, look, when the symptoms start early, treat it early. Don't wait till it gets so severe that you can't even return from it. And how do we do bladder preservation? Well, the hallmark treatments to start with are going to be meds like Flomax is a classic one. Finasteride is another one. And there's a whole, sometimes we can use Cialis as one. There are a whole host of meds like Flomax, alpizose and Zolidose and Capsules and another name for Flomax. So, there are a whole host of meds similar to Flomax that we can use. There's another medicine similar to finasteride called dutasteride. Other names are Proscar. And then there's Cialis or tadalafil, which are erection medications that can also help with urination to some degree too. These meds do come with side effects that you should know about. The big one for Flomax is retrograde ejaculation. So when you have sex, you may notice that you just don't expel or ejaculate quite the same volume. You can get lightheaded if you suddenly stand up, so we usually recommend if you're going to take Flomax, take it at night, not the daytime. Finasteride, you can get decreased libido, decreased sex drive. In rare cases, there's something called finasteride syndrome where you can even get depression and suicidality. The problem with finasteride syndrome is that can be a permanent thing. Even if you stop finasteride, that may not reverse. I have never seen it in my practice, but it may be there, and may be subtle. I don't use a lot of finasteride in my practice primarily because of that finasteride syndrome, but some patients, like elderly patients, aren't too concerned about that, and they opt for maximizing medical treatments. Cialis is a nice option if you also have ED. You can kind of treat two birds with one stone. Cialis does come with possible headaches, nasal congestion, heartburn, muscle aches, and you cannot take it if you take nitrates for chest pain. Keep in mind that enlarged prostate is the oral medications are more like Band-Aids. They work when you take them, when you stop them, symptoms typically just return. So that is something worth keeping in mind. A lot of patients opt for surgical treatments. The most minor of them is called a Urolift. A Urolift, the way it works is it's about a 5-minute in-office procedure. We can do it in the hospital if you just don't tolerate in-office stuff, but typically it's pretty easily done in the office. We do numb you up, and then we put a little camera through here, and using the camera, we can actually put these little compression clips or stitches, and what the stitches do is they just kind of open up the prostate, kind of like pulling a curtain open. There's certain criteria you have to meet to be a candidate for this. You can't have like this large blocking third lobe in the prostate, because this is just not a good device for that. You have to be able to retract the side, so if it's too big of a prostate, well, these clips won't be able to actually reach the ends. And so this treatment won't be helpful. And so those are some things that we sort of determine for you. Now, Urolifts, in essence, every treatment we're going to have has a lifespan. Urolifts, the 5-year data shows that it's working pretty well. There's like newer 10-year data that shows that for a lot of patients the effects last. But I will say that there's usually a declining impact, as in over the course of time, your prostate will continue to grow, and even if your clips are here, over the course of time, your prostate will grow back. And so eventually you may need a Urolift again, or you may opt for a different treatment. But the best thing about a Urolift is that there's not as much downside. The biggest risk with some of the other treatments is something called retrograde ejaculation. The same side effect you get with Flomax, but permanent, where when you have sex, you do not see any ejaculate. Sometimes you can have ED from some of the other ones, and that's because your nerves for the erections run right around the prostate. And so if you're using energy in there, you could technically cause some erectile dysfunction, although not that common. But the bigger risk is you can permanently get retrograde ejaculation, because if you remove the neck of the bladder, the neck can no longer contract when you're trying to ejaculate, and so your ejaculate will preferentially go into the bladder instead of expelling out. So we call that retrograde ejaculation. Urolift does not have that risk because we preserve the whole prostate, and including the neck of the bladder, and we only compress the middle areas. And so that allows you to preserve your sexual function in general. So the biggest benefit to Urolift is you don't burn any bridges, you can still continue to move down this track, and you preserve your sexual function. Number 3, we have several different options. I kind of lump them all into something called TURP. So anything that shrinks, reduces, removes tissue in one way or another, you put under the transurethral resection of prostate, just because that's the general term for removal of tissue. And the classic one is shaving, physically going into the camera and shaving this tissue here. So that now this does cause respiratory ejaculation because you do shave that neck. There's a version of this called aqua ablation. There's a version of this called aqua ablation where it can actually preserve, you can robotically sort of map out the prostate and you can preserve that neck a little bit, they say about 80 to 90% of the time. And if you can preserve that neck, then you can preserve your ejaculation. So about 80 to 90% of patients with aqua ablation do tend to preserve that erection. It does come with increased risk of bleeding during the procedure or immediately after, so just keep that in mind. But it is a newer procedure that allows us to use some robotics to kind of map things out. These are typically done in the hospital. There is something called a green light laser. And this is great for patients that are high risk for bleeding or trying to limit bleeding, again, not in the hospital. But we can use a green light laser and sort of burns the tissue instead of just shaving the tissue. Again, we have your classic TURP, which I'm a big fan of also. And this is your go-to bread and butter TURP, the old school rotor-rooter that we still do. It's been around 40 years. This is the gold standard that every other treatment is compared to. So this is the one with the most treatment data. And any treatment that came out after that is really compared to the TURP. So, they have great results. It's tried and true. Just about every urologist really should know how to do a TURP. And so the TURP is oftentimes a like go-to procedure that insurances are almost guaranteed to cover and has known results, right? So proven results, better than anything else in existence as far as the amount of data out there. When you start getting into really large prostates, so when you start getting into big prostates, then we start oftentimes talking sometimes a green light laser. But then oftentimes you can also have something called a simple prostatectomy. And so what these procedures are again, a green light laser can laser the prostate. Larger prostates tend to bleed. A green light laser, we're going again through the penis, so it's more minimally invasive. I'm a big fan of it. Sometimes, because if it's too big, we have to limit the operative time because too much anesthesia can be bad for you too. And sometimes we have to say, okay, let's call it quits, and we may need to repeat the procedure, or we think we're done, but some of the tissue kind of grows back, and because it's such a large prostate, and sometimes you need a repeat procedure. With a simple prostatectomy, oftentimes you can do it all at once, but it's much more invasive. It involves going in either open or robotically, going in and scooping out the prostate. So we go into the abdomen, into the bowel, cut open the bladder, scoop out the prostate, then sew everything back in, put a catheter in, and let you heal from that. So those are treatment options for very, very large prostates. You're going to hear about a ton of other treatment options. Resume is a procedure typically done in office. I found it's a little painful, so I haven't dwelled as much into it, but those are treatment options we can always discuss. There's something called a PAE, which is a newer treatment done by interventional radiology, where they're blood vessels that feed the prostate. And what they do is they go through your arteries and find where the biggest blood vessels are, and then they put little clips that block that blood supply. And by blocking the blood supply, the prostate starts shrinking. And over the course of time, you can have good results. PAE is another option that really works with really large prostates. With small prostates, it's really hard to find those vessels. So another option that's good in that large prostate area. So again, we have lots of options to talk about. You have lots of treatment options. I would say I'm a big fan of early treatments rather than waiting until you get to a point of no return. So keep that in mind. Again, this is Dr. Shah with 360 Urology in Atlanta. If there's anything you ever want to talk about, come find us. All right. Thanks.